Good afternoon, everyone. Thank you for joining us today for the GI Liver workshop. I am Nicole Green, a pediatric gastroenterologist at Seattle Children's Hospital. I will be co-moderating today's session with Flora Sabo, a pediatric gastroenterologist at Children's Hospital of Richmond at VCU. We are really excited about today's talks covering the latest results of ongoing or recently completed research studies on a range of high interest GI and liver topics. Dr. Christabella Ng will be starting us off discussing the effects of tezacaftor, ivacaftor on gut function in cystic fibrosis. Next will be a presentation by Dr. Sarah Jane Schwarzenberg with a 6-month report of PROMISE GI, the effect of elexacaftor, tezacaftor, ivacaftor on GI symptoms, and her questions will be answered by Dr. Steve Friedman in her place. She will be followed by Dr. Baha Moshiri with results from Galaxy, looking at GI symptoms in people with CF. Followed by Dr. Michael Narkowitz, who will be discussing the final results of the PUSH study. Heterogeneous ultrasound predicts high risk for the development of advanced liver disease in CF children. And last but not least, Dr. Emily Scala will be discussing plasma proteomics identifies vascular disease, thrombocytopenia, fibrosis, and dysregulation of lipid transport in CF patients 3 years prior to nodular liver ultrasound. After each recorded talk, there'll be an opportunity to pose questions to the speaker. So please remember to type your questions as they arise during that talk into the question box, and we'll get through as many as possible. And again, please ask the questions for just that talk that is happening at the time. So without further ado, we'll move on to our first presentation with Dr. Christabella Ng.
Hello, my name is Christabella Ng. I'm a clinical research fellow from Nottingham in the UK. Thank you for allowing me to present our work on the effects of tezacaftor, ivacaftor on gut function and transit in cystic fibrosis, a randomized, double-blind, placebo-controlled crossover trial. These are my disclosures. Before the introduction of highly effective Cftr modulators, research groups from the UK and Germany highlighted the high prevalence of GI symptoms in the CF population. In addition, our research group reported that at least 2/3 of people miss school or work due to these GI symptoms. Although we're able to identify these symptoms through GI questionnaires, the treatments that we are using are based upon other gut disease mechanisms and are likely to have different underlying pathologies. Recent pivotal phase 3 clinical trials for Cftr modulators have been successful in showing improvements in lung function, but the information about their effects on GI disease are minimal. Although there are outcome measures for GI symptoms through the CFQR questionnaire, these questions are limited and do not focus on core GI symptoms like the CFAB score and PACSIM questionnaire. There are not many other clinical trials which objectively measure the GI effects of new combination modulator therapies. We have previously demonstrated that it is feasible to use MRI in assessing transit times, small bowel water, small bowel motility, colonic volumes, and observe the texture of the GI tract. Alongside patient-reported outcomes, MRI provides objective GI measures without subjecting the patient to invasive procedures or exposure to radiation. We already know that GI symptoms and complications persist, and that there is a proposed cycle of inflammation, dysbiosis, and dysmotility that contributes to them. We have previously shown that there is an increase in the amount of small bowel water in people with CF that is possibly due to a subclinical blockage. In this simplified diagram, on the left in health, water from the small bowel can pass through the ileocecal valve freely after a high-calorie meal, which means that after the meal, the amount of small bowel water content drops. And if we compare this to the image on the right, in the CF gut, where there is potentially subclinical obstruction, the outflow of small bowel water into the ascending colon is reduced. Therefore, the drop in small bowel water after a meal is much less. We have called this drop the delta TI. There are some studies that have shown there to be some insight into what happens in the presence of ivacaftor, such as the US Smart Pill data that showed changes in the duodenal pH after a month of ivacaftor, and the Kiwi and arrival studies that showed there to be recovery of pancreatic exocrine function after 24 weeks. However, there is little data on what effect new combination CFTR modulators have on gut function and symptoms. We therefore aimed to evaluate the GI effects of Tez-Iva in people with CF using MRI. We hypothesized that whilst taking Tez-Iva, oral cecal transit times would be faster, small bowel water content would be reduced, the drop in the postprandial small bowel water content would be increased, and the colonic volumes would be reduced, and GI symptoms would be improved. We conducted a randomized controlled crossover trial where we aimed to recruit 12 people with CF homozygous for delta F508 and aged between 12 and 40 years. We gave Tez-Iva and compared to placebo, and our primary outcome was the oral cecal transit time, and our secondary outcomes, as you can see on the slide. For the colonic volumes, the small bowel water content, and delta TI, we adjusted full body surface area due to the wide age range that we aim to recruit. Enrolled participants underwent a series of baseline MRI scans before being randomized to 28 days of Tez-Iva or placebo. After a 28-day washout period, they switched to the alternative treatment arm. And during the third week of each treatment arm, they underwent a series of MRI scans. The Mri Study Days, which also included completion of GI symptom questionnaires, involved 11 MRI scans, which we have previously reported. Participants arrived fasted for their first scan and then were given a set breakfast meal. Following this, they underwent 10 further MRI scans, initially at 30-minute intervals and then at hourly intervals, and they were also given a set lunchtime meal. We used previously validated methods for MRI research analysis. Oral cecal transit times were determined by the time taken for the head of the meal to be identified at the cecum, whilst colonic volumes were calculated by drawing around the colon. Small bowel water content was calculated by using the cerebral spinal fluid as a water threshold value and then drawing around the small bowel. Small bowel water measurements were taken at each time point and then plotted on the graph so that the area under the curve could be calculated. In addition, we measured the delta TI. This was the change in the amount of small bowel water after a high-calorie meal is given. A larger value indicates that a larger volume has moved from the small bowel into the ascending colon, whilst a smaller value indicates that less water has moved from the terminal ileum into the ascending colon, and this could be due to obstruction. We enrolled 15 participants to the study, but 2 were excluded because they either found the MRI claustrophobic or did not like the first meal. We randomized 13 participants to a treatment arm, but 1 did not attend any of the MRI visits. And therefore, we had a total of 12 participants who completed the study, of whom 8 completed the study per protocol, and 4 underwent observer-blinded study visits. For the observer-blinded visits, the participants were not blinded to treatment and underwent baseline MRI scans when they were off treatment and MRI scans whilst they were on treatment. The researchers analysing the data were kept blind. And this was due to the COVID pandemic, when all research scanning was paused. During the study pause period, patients were given access to Tes-Iva as part of their routine treatment, and therefore we felt it was unethical to delay their access and keep them in the study protocol, whilst we acknowledge that it meant our methodology was not as robust. These are our baseline characteristics. We had an average age of 22 years. There were slightly more males than females, and they were all homozygous for delta 508. The baseline height and weight are, as you can see, and the average FEV1 is 78%. Only one participant had a history of DIOS. Our primary outcome showed that after a month of Tes-Iva, there was no difference in the transit times. The upper limits of both the placebo and Tes-Iva groups were more than 6 hours, and due to the scanning period, we were not able to calculate accurately the transit times outside of scanning. As you can see here, approximately 50% in both the Tes-Iva and placebo groups were not able to complete their transit time in the scanning timeframe. I have also shown on this graph the data from our previous study, where all the healthy controls had transit times calculated within the scanning timeframe, and therefore you can see that their transit times were quicker than our current study group. Moving on to our secondary outcomes, the area under the curve for the colonic volumes over the course of the scan day did not change when given Tes-Iva. The fasting colonic volumes were also not different between the two groups. However, the colonic volumes were still higher than normal. Our small bowel water data shows the physiological trend of small bowel water movement. In the first hour after the first meal, there is a slight drop in small bowel water content due to the absorption of readily available nutrients such as glucose and sucrose in the liquid phase. The small bowel water levels then recover by the time of the second meal, before then having a further drop due to the gastroileal reflex, which empties the ileal content into the ascending colon. After a month of Tes-Iva, there was no difference in the overall small bowel water content compared to placebo. If we focus on the delta TI now, you can see from the graph that there's no difference between the two groups. The Tes-Iva group had a median delta TI of 28 mils per meter squared, whilst the placebo had a median delta TI of 19 mils per meter squared. Most of the participants did report GI symptoms, and these were all identified in the CF score. However, the GI symptoms did not change after a month of Tes-Iva. And what we can see from the CF score in the spider diagram is that the highest scoring domain was in the disorders of bowel movement in both groups. Our data does correlate with our previously reported MRI data, and we can make comparisons with the CF group in the GIFT-CF1 study and the placebo group in the GIFT-CF2 study. In addition to the prolonged transit times that I have previously reported, our data show that in particular the delta TI and the colonic volumes in the CF groups without modulator therapy are similar. The delta TI in both studies are reduced in the CF group and the placebo group, and the colonic volumes are increased in the CF group and the placebo groups. These results have not changed after Tes-Iva. And the comparisons between the two studies show that we can use MRI as a platform to evaluate gut function in CF. Our data also correlates with the Gelfond group, who used wireless motility capsules to monitor GI transit times. And similarly to our study, after a month of ivacaftor, you can see here in the graph that there was no difference before and after ivacaftor in gastric emptying, small bowel transit, colonic transit, and whole gut transit times. Other studies have published data to show that the gut inflammatory marker, fecal calprotectin, improves after 6 months of ivacaftor. And the pancreatic insufficiency is reversed as seen by the improvement in fecal elastase levels after 24 weeks of ivacaftor. These studies highlight the GI effects of modulator therapies may only be seen after longer treatment periods. There have also been in vitro studies that use intestinal organoids to evaluate CFTR function by assessing the amount of swelling. In this study by Firstover, I have taken a snapshot of their assay results, but they all showed that the triple combination therapy seen in the dotted line was more effective in improving CFTR function than the tes-iva shown in the dashed line. And this was still more effective than no modulator seen in the solid line. So in conclusion, we have generated the first data in evaluating GI effects of a CFTR modulator using MRI. But future studies are needed to evaluate the longer-term use of combination therapies. More effective modulators, larger sample sizes, or longer treatment periods may reveal statistically significant effects. And these data continue to supplement existing data for using MRI in CF gut disease. I'd like to thank our funders and my collaborators for making this study possible. Thank you for listening.
Hi, thank you, Christabella. That was great. As you can see, we have a few questions in the chat. So I will just go through them. So the first one was, why did you choose 28 days for the time period? And I think you touched on this a little in your discussion, but do you feel like this was a long enough time to see change, or would you have ideally liked to follow these patients a little longer?
That's a really good question, actually. So 28 days, when looking back at the other clinical trials that were focusing on the lung function, after 4 weeks, there was a significant change in lung function. As we can see in our results, it probably wasn't long enough for all the changes to take place in the gut. We really hope that there are changes that occur in the gut because of the CFTR modulators. So I think in future we will need to look at the effects of modulators for longer periods of time.
Great.
Not enough.
And quick question about the medications. Were any of these patients on medications prior to the study, or pro-motility agents, or how did you control, I guess, for various medications?
So all the participants stayed on their usual medications. If they were taking any laxatives or any antidiarrheals, they were asked to stop them for the day of the scanning, because it would have affected all the results. And they all did that quite comfortably.
Okay. And then the meals as well, were they sort of standardized for calories and for all the age groups?
Yeah, so we had set meals for a set breakfast. So they had rice pudding mixed with a bit of cream and jam, a glass of orange juice and a glass of water, and they had to finish that meal. Otherwise they wouldn't be able to go on to have the rest of the scans. For their lunchtime meal, again, it was set. This was macaroni cheese, strawberry cheesecake, and a glass of water again. And again, they were encouraged to finish those meals, but we weren't as strict for that meal. It was just until they were full, but pretty much everyone, in fact, definitely everyone had the whole meals for both time points.
And quick question about study design. How did you decide on the sample size? Obviously, there are the unanticipated effects of COVID, which affected final numbers, but just in terms of sample size for your study.
Yeah. So it was quite a small study. It's a pilot study that's never been done before. We didn't have any other data specifically within CF groups. So at previous data, we weren't able to make a sample size calculation for this one. 12 seemed to be a good number for a crossover trial. So that's how we came about doing that.
Okay. And do you have plans to continue this study with like Trikafta or other aims for your group?
Yeah, so we're currently looking at Cftr data. So things are to come, looking over a longer period of time with more effective modulators. I think we really need that data out there. It's progressing fast.
Yeah, exactly. And then there's a question about this, how long the scanning time is in the MRI based on your protocol and other potential measures. So sort of gastric volume, can you do that with the same technique?
Yep, so we do look at gastric volumes as well. We calculate the half emptying times, and this helps us analyze the transit time data to decide whether or not it's gastric delayed or whether it's all small bowel. So we have looked at that, and does that answer the question?
Yep.
Sorry.
It was. Yeah, I guess sort of part of the question is also like, especially if people are thinking, maybe down the line, obviously this is a research setting, but how burdensome is the protocol for participants? Like, is this something that would be even something that in the future would be considered clinically, and sort of what, is the cost for the scans? Obviously you're in England, but sort of how you're thinking about MRIs and utilization.
Yeah, so this is you're right, quite a burdensome protocol. I think whilst we're gathering data on the unknown, we need to have quite a long study day, but in the future I would hope that we can start trimming that down and focusing maybe more on the delta TI, which would just need to include 2 of the time points, and reduce the burden of investigation on patients. The total costs of the scans are expensive, especially because you're having to have the patients in for a whole day. But like I say, if we can reduce it down to those 2 scans, then it'll be much cheaper.
Okay. And does your center have a dedicated research MRI? Is that how this study was?
Yeah, so without our dedicated MRI scanners, it would be really hard to do these scans because they get booked up. Even our research scanners get booked up well in advance.
Okay. Yeah. Well, thank you. That was really exciting. Look forward to future work. Thank you. So I think we can move on to our next recorded talk, which will be by Sarah Jane Schwarzenberg. So this is the PROMIS GI report for GI symptoms.
My name is Sarah Jane Schwarzenberg. I want to thank the organizers for asking me to present this abstract. This is the 6-month report of PROMIS GI. PROMIS GI is an observational study of elexacaftor, tezacaftor, ivacaftor to determine if it alters gastrointestinal symptoms in people with CF. This is my disclosure slide. None of the relationships that I have at present have an impact on this presentation. In PROMIS GI, we hope to better understand the impact of ETI on gastrointestinal symptoms and health-related quality of life related to GI wellness. We are utilizing the patient-reported outcomes measures utilized by the Galaxy study, including PEC-SIM, a patient self-assessment of constipation symptoms, PAGI-SIM, a patient self-assessment of upper gastrointestinal symptoms, PEC-QOL, a patient self-assessment of quality of life related to lower GI disorders. In addition, we're using the Bristol Stool Scale, which is a pictorial self-assessment of stool form. We are also doing 3 stool studies, one to look at intestinal inflammation, that is fecal calprotectin, and then exocrine pancreatic function as measured by fecal elastase 1, and non-pancreatic malabsorption measured by fecal steatocrit. All the patients serve as their own controls in this study. Today, I am showing you the results for the baseline prior to starting ETI and 6-month time points. These are our key demographics. The age group for the PROMISE study is greater than 12 years of age. And when we divide those age groups into some clusters, we find that we have a pretty good distribution of age groups across the study. We also have a pretty even division between males and females. Many of our patients had prior modulator use. About 49% were modulator naive, and the rest had used modulators at the time they were about to start ETI or in the past. COVID did have an impact on the completion of some of the portions of GI PROMISE. However, even at 6 months, we still have a 63% completion of our patient-reported outcomes measures. I'm going to walk through this particular graphic because it represents the style of the next 3 slides. So these are the results of the PAGI-SIM, or upper GI symptom assessment, at 6 months. As you can see at the top of the graphic, we have divided this into age subgroups with less than 18 years, or if you will, between 12 and 18 years on the left, 18 to 30 years in the middle, and older than 30 years on the right. The blue squares represent male respondents, and the pink triangles represent female respondents. On the left, we have the total score, and then going down on the left, each of the domains for the PAGI-SIM. And if you look at each of the age groups, you see a red dotted line in the middle of the gray background. That red dotted line represents the results at baseline. And the squares and triangles represent the variation from baseline at 6 months. As you look at this, I think it's apparent that there has not been an enormous change. Changes to the left of the dotted red line represent improvement. Changes to the right of the dotted red line represent worsening of the symptoms. And the most obvious changes occur in the domain of bloating, where interestingly we see some improvement in women and some worsening in males, especially in the older age groups. The changes, however, overall are fairly small, and it's unclear whether they have any clinical significance. This is a similar graphic for PAC-SIM or lower abdominal symptoms. Again, I think we can see that while there appears to be small changes, particularly in the area of abdominal symptoms, there are not significantly large changes from the baseline prior to the use of ETI. And finally, this is the PAC quality of life 6 months changes. Again, we're looking at the different age groups at the top and the domains on the left. The most change that we see is a reduction in dissatisfaction among males who are less than 18 years of age. But the changes here are actually very small. With respect to the Bristol Stool Scale, we do see some changes from baseline. If you look at the left, stool type 1 or 2 is a constipated stool, and that does not change at all from baseline. However, we do see a slight increase in diarrhea, both at 1 month and 6 months after starting ETI. These changes are not significant, but they do correlate with some of the anecdotal reports that we've had of diarrhea in people starting these highly effective modulators. Turning now to the stool studies, fecal calprotectin was lower at 6 months compared to baseline. As you may remember, fecal calprotectin was lower at 1 month after starting ETI. We don't know at this point whether this represents an intestinal change in fecal calprotectin or a change in fecal calprotectin from the airways. However, it's fairly consistent across 6 months. You can see in this slide that the changes in fecal calprotectin appear to correlate with the changes in weight that patients who are on ETI experience. Here we're looking at change in body mass index Z-score for our pediatric population against changes in fecal calprotectin. Similarly, and a bit more strikingly, we see a similar result in adults with an association of the changes in fecal calprotectin with the changes in BMI. This does not necessarily suggest cause and effect. It is, however, an interesting finding to pursue. We saw no change in fecal elastase from baseline to 6 months. As you can see in the results from this slide, we actually have pretty much the same percent of people with severely abnormal fecal elastases before we start ETI and 6 months into ETI. There was also no change in fecal steatocrit from baseline to 6 months. So in conclusion, after 6 months of highly effective modulator therapy, that is ETI, fecal calprotectin, which may reflect intestinal inflammation, remained decreased from baseline as it was at 1 month. There was no substantial change in fecal elastase 1, and there were no substantial changes in gastrointestinal symptoms from baseline. The percent of people reporting diarrhea while on ETI trended towards an increase. We speculate that ETI, while it may lead to improvement in lung function, may have little or very delayed impact on gastrointestinal symptoms in people with CF. I'd like to thank and acknowledge all the members of the PROMISE GI study, and I would like to thank the PROMISE core study team for supporting the GI work. Thank you.
Great, thank you. And thank you, Steve, for being here to answer questions on that talk. So one of the questions was, do you know if lung function improved in patients with the decreased fecal calprotectin levels?
Yeah, I mean, we know in the PROMISE study, just like in the studies leading up to its approval, that lung function does improve. I think that's one of the main questions is the fecal calprotectin reflecting a decrease in neutrophils that you're swallowing from the airway, or is it truly inflammation of the GI tract is settling down? We're not sure. Probably it's a combination of both if I had to speculate here.
Okay. And then another question, how often, based on these results, how often would you recommend checking fecal elastase levels?
Yeah, so we'll see, by the end of the 2 years of this PROMISE study, what happens to fecal elastase. Prior published studies clearly show that modulator therapy can improve or rescue the exocrine pancreatic function. As a result, fecal elastase comes up to 200 or higher. So that's up to age 5, CLIMB study, et cetera. I think PROMISE is obviously looking at age 12 and above. And so far, people age 12 and above were not rescuing their pancreas, exocrine pancreatic function. I think we'll see as the study goes on, but probably if this, really isn't changing, then I'm not sure you have to keep checking it. That said, there's a paper that's at least in press, if not out already, Journal Cystic Fibrosis, that in a few patients in their 20s, their exocrine pancreatic insufficiency was rescued. And as a result, these patients now presented with pancreatitis. So there perhaps is a small subset of patients where you can reverse the exocrine pancreatic insufficiency. So, I think we'll see over time, who do we check? In part, I think we'll go by patient symptoms, but I think we'll see over the next year or two how often we should be checking this.
Great. Another question in the chat was, did you sub-analyze the changes in symptom scores for those who had worse symptoms prior to starting ETI? Or I guess we were presented with sort of the change in scores. How severe were these scores at baseline? Do you have a sense of that prior to starting?
Yeah, we did not, as I'm just looking at the data here, we did not do sub-analyses. It was mostly splitting by age and splitting by male versus female. So so yes, we do not have that data.
Okay. Yeah, because anecdotally, I think a lot of people think that they feel better from the GI standpoint on these modulators or on triple combination therapy. Do you think, or have you been able to identify any potential predictors of GI changes or GI improvements in these patients?
Yeah, I have not. I wish I was out of business as a gastroenterologist because we've made all the GI symptoms go away, and we have not seen that. I think there's one thing that there's no question of. We are not seeing the dramatic impacts that we see in the airways reflected on the GI tract in most of our patients. There are a subset of patients who, yes, their constipation is somewhat better. Maybe their abdominal pain is better, but it's still a smaller minority. And in part, I mean, we don't know if, a year to 2 years out, maybe that's how long we have to wait to see the full effect of these highly effective modulators. We know outside of CF that For example, if someone has malrotation and you do corrective surgery, their motility doesn't instantly get back to normal. It takes like a year. And we know that CFTR is in the enteric nervous system. So probably not surprising, even if you're improving CFTR function in enteric neurons to start to correct the motility disorder that's associated with CF, that's probably going to take several months or longer before you may truly see that.
Yeah, exactly. And did you capture in the study any information on the participants' diet or any changes in diet?
Yeah, we've not captured that in the study. I think that's something that definitely needs to be looked at. And, I think in part, it's a whole new era with these highly effective modulators of what do we do with nutrition when it comes to these patients. And, dietitians are doing an amazing job of kind of assessing this. I think the, old approach of everyone gets 3,000 plus calories, the highest fat they can possibly consume, live at McDonald's eating Big Macs and French fries. That's not something we should be doing. And in fact, overweight and obesity is now becoming an issue. So I think we need to step back on the diets. I think we need to see what diets make sense and how that impacts GI symptoms here, as well as just kind of overall nutritional status. At our institution, we're starting a study now looking at kind of low glycemic, low carb diets. What effect does that have on gas, bloating, abdominal distension, and markers of glycemic control?
Okay. There's another, the fecal elastase questions are popular. So so as you might expect, almost all the participants were obviously pancreatic insufficient. Do you think that affects the interpretation of the results, that most of these people are pancreatic insufficient?
Yeah. I mean, almost all these patients, the majority are pancreatic insufficient. There are some great presentations and studies by Kevin Gaskin and Peter Dury quite a few years ago. And I remember Kevin Gaskin was showing that the people that he could rescue who were, I can't remember the age group, it was like late teens, early 20s, if I remember correctly, were people that had fecal elastase in that 100 to 200 range, more like 150 to 200. So there is already some preserved function. So more likely that you can get a turnaround of those patients. I think if someone has complete fatty replacement of the pancreas or complete fibrosis of the gland, there's no acinar cells that you can get back to being functional. So I think those people that are a little more on the cusp are the ones that probably we're going to find these highly effective modulators can turn around. We did not have those types of patients in the PROMISE trial.
Okay. And then I think we have time for one more question about the bloating. I think there was increase in bloating, at least in males, and that has been observed by other people clinically. Was that statistically significant in your results, and any hypothesis as to the cause of increased, say, bloating in the males or decrease in females?
Yeah, bloating, I think everyone in GI knows it's tough. It's tough to know exactly what's driving it. Is it just the dysbiosis? Is it altered motility? Obviously, someone has CF-related diabetes that predisposes to bacterial overgrowth and this dysbiosis. So I'm not sure the answer here and what causes the increase. We're not seeing dramatic effects on bloating. We're hoping if we're turning around the microbiome, the dysbiosis, with these highly effective modulators, would that have an impact on this symptom? Not seeing that yet. We will be seeing results over time in the PROMISE study on the microbiome, both in the gut, airways, that will be coming out over time in the study. And I think that'll maybe give us a better sense of at least on the microbiome side, are we modulating that? If not, or is it going in the wrong direction? Does that explain what was brought up here?
Okay. All right. Well, that was great. Thank you again. And I think we have the perfect next talk after yours. So we have Dr. Baha Mashiri with the results from Galaxy, looking at GI symptoms in people with CF.
Hi, everyone. This is Baha Mashiri, and I'm from Atrium Health, and I will be presenting to you guys at this Cystic Fibrosis conference today. I will be talking about GI symptoms are being common in people with cystic fibrosis, and this is regardless of GI medication usage. These are the results from our Galaxy study, which is a multi-center study with which many of you guys are probably involved. This slide is my disclosures that are reported here, including grant support, speakers bureaus, advisory boards. Besides this, I also have grant support from the NIH as well as the Cystic Fibrosis Foundation, who is really responsible for the study that we will be presenting today. So just as a background, we all know that dysfunctional CFTR leads to constipation and then other symptoms that we see in cystic fibrosis, including gastroesophageal reflux disease, decreased fluid secretion leads to many of the symptoms, including constipation, intussusception, rectal prolapse, dysbiosis, which we refer to as small intestinal bacterial overgrowth, inflammation, increased intestinal permeability, and then other many dysmotilities, including gastroparesis. And so we really have been trying to come up with these electronic patient-reported outcomes measures that would be easy for patients to fill out in an out-of-clinic environment, especially for the last 2 years with everything going on with COVID. And these perhaps would be more favorable for doing clinical research. And so we have come up in Galaxy in this multi-center study with a group of questionnaires, and this report of this design of the study has now been published. And we found that there's very little variability in the questionnaires that we have chosen in our EPROMs, that they were feasible, sustainable, and reproducible from week to week over this 4-week period of time. And we'll talk about these questionnaires specifically later. And then prior to starting Galaxy study, we asked some providers and dietitians about their comfort level with managing constipation. And there was 557 respondents, a lot of dietitians, thank you so much, and then many providers. And looking at the dietitian reports, they were very comfortable with using PEG, dietary changes, of course, not so much with magnesium, but very comfortable with giving pancreatic enzymes to patients with CF. Diagnostic testing was recommended by 66% of them. And then they did refer to gastroenterologists 87% of the time. But when we looked at the providers, their comfort level with diagnostic testing was only with x-rays. 98% said they were comfortable with an x-ray, but really transit studies such as SITS marker study, anorectal manometry, and others, they were not so comfortable with. As far as cleanouts, they were very comfortable with PEG, but not so much with mag citrate. They didn't use it as commonly. And then maintenance therapy, very comfortable with using PEG for maintenance, but not any other laxatives for constipation. And then when you look at the comfort level with managing gas, bacterial overgrowth was considered by our dietitians at 36%. Probiotics, a total number of respondents was like 90 that said they suggested probiotics in patients. That was in 88% of the patients. Diagnostic testing was recommended by 60%. And then other agents such as simethicone, again, dietary changes were considered. In the provider comfort with gas, we had over 300 that responded. Thank you so much. And then, they said, yes, gas is frequent, and 77% reported that they thought it was a very frequent symptom of patients with CF. And 23% of them were comfortable with treating bacterial overgrowth. The most common antibiotic they used was metronidazole. That was an 87%. And 44% of respondents used and were comfortable with using rifaximin. So really, this is important to know what we all feel comfortable with doing and treating, and how we all think that CF patients, what symptoms they have most in common, which constipation is one of them. So we all know severe constipation leads to poor quality of life. This is just in the general population that filled out the PAC-SIM and the PAC-QOL questionnaire, similar to our patients. And then the definition of constipation in cystic fibrosis kind of need some help, the Espegan group, CF working group specifically looked at the definition and came up with this definition for constipation in CF, which includes abdominal pain or distension, reduced frequency of bowel movements in the last few weeks or months, increased consistency of stools in the last few weeks or months. And then number 3 is symptoms 1 and 2 are relieved by use of laxatives. And so their definition of constipation was number 1 or number 2A or number 2B and number 3. So we can all see that this is, really complicated. And the Rome questionnaire is also not easy to follow for patients with CF because abdominal pain is a common symptom that's seen in constipation in CF. But in Rome, that would be called IBS with constipation. So perhaps, this is something that needs to be changed with time. And then when we looked at our results of our Galaxy study, we saw that even moderate to very severe symptoms on our questionnaires were reported by both of the age groups, the less than 18 as well as the over 18, and that the individual symptoms of bloating, upper abdominal pain, early satiety, fullness, postprandial pain, and constipation were reported as severe and moderate in over 20% of the patients. So really moderate to severe symptoms, these specific ones, were reported in over 20% of the patients. So we really have room to target for therapy, future therapy. So in this specific study, we took the same patient population, obviously, over 2 years, and we looked specifically at medication usage. This was collected at the beginning of the enrollment into Galaxy, and we looked at total and domain scores for the fully completed EPROMs. The EPROMs are the PAG-SIM, which is a constipation symptom questionnaire, the PAGI-SIM, which is a general GI, includes upper GI symptoms, even reflux, and lower GI symptoms. Then there's the constipation-related quality of life score, which was also collected over 4 weeks. And then we also had some supplementary questionnaires that was expert consensus that we decided were important to capture, such as fecal incontinence, and then frequency of bowel movements. And, we looked at all of that in relationship to whether the patient in the subgroups of interest were on Cftr modulators, constipation meds, and acid suppression medication. And then we compared them to the groups not on these medications. So the demographics of the study, 55% of the patients that were recruited were male in the less than 18 age groups, and then 49% were over 18. We had mostly Caucasian, 97% are Caucasian with cystic fibrosis, 94% in our patient population were adults that are white, and then less are Black, Asian, and others. And then genotypes, the most common was the F508 homozygous, 52%, and then 53% in the adults. Pancreatic insufficiency was seen in over 88% of the patients, adult and children. And then use of modulator was seen in 48% of the children less than 18, and then 62% in those over 18 years of age. And then more specifically, looking at medication usage amongst people with CF in our study, constipation meds were used in 52% of children, 33% of adults, 48% were PEG, and then 29% of the adults used PEG, and then 7% used Senna in the children, 2% of adults used Senna, and then other constipation meds are fiber supplements, linaclotide, lubiprostone. So prescription medicines were not used very often for treating constipation. And then acid suppressant agents were used in, proton pump inhibitors specifically was the most common. And that comprised 42% of the children that were on them, 52% of the adults that are on them, followed by H2 receptor antagonists. So when we look at the pharmacologic treatments available for treating constipation, there's many now, right? So this has just really expanded and escalated in the recent years. And so we've gone, we have stimulants, we have osmotic laxatives such as PEG, which was the most commonly used treatment for treating constipation in CF, followed by stool softeners. And then we have these pro-secretory agents such as lubiprostone, linaclotide, flecainide, tenapanor. These have different mechanisms, but they are all secretory agents. And then there's prokinetics, which are agonists of serotonin. And this is a treatment such as prucalopride, which are used in the general population often for treating constipation. And then specifically for treating constipation in cystic fibrosis, there are studies in these are marked by studies that are available in pediatrics and adults. Lubiprostone, for example, there's studies, CF studies in both children and adults. And then there's plecanatide, linaclotide, stool softeners, hydration, and PERT therapy. Adequate PERT therapy are also important here. But really, there's not huge clinical trials that have been done in CF for treating constipation. So the results of our study are now going to be reported here in the subsequent style. So looking at constipation treatments, again, they were the most common after pancreatic enzyme therapy, followed by acid suppression therapy. And so specifically looking at total and domain scores by use of constipation meds, and this is mean difference by use of constipation treatment. So when you compare those on constipation treatment versus those not on constipation treatments, it looked like the EPROMs scores were higher amongst those that are on constipation treatment. And that's specifically with respect to stool symptoms, especially bloating, upper and lower abdominal pain, and then dissatisfaction with current constipation treatments. When we look at acid suppression agents, it's very similar to with constipation treatment, and the scores are all higher, specifically bloating and dissatisfaction with treatments are high. Whether the bloating is from constipation, we do not know, but the bloating can be kind of a manifestation of upper and lower GI symptoms. But patients on proton pump inhibitors reported more bloating on our questionnaires than those not on proton pump inhibitors. And then importantly, we know that the CFTR treatments, especially ivacaftor, has been studied with the wireless motility capsule. Studies done in cystic fibrosis versus a control group showed that small bowel dysmotility does exist in, and it is a consideration in patients who have cystic fibrosis, but other gut dysmotilities was not seen, at least on this small study, where we don't actually have phenotypes of the CF patients, so we didn't know if they had GI symptoms. But when they looked at ivacaftor, it changed pH, but it did not have any, it did not lead to any change in GI transit based on wireless motility capsule testing. So we do not know whether CFTR modulators will really affect change, their transit or their symptoms. And so now we look at the CFTR modulators, and this is, symptom scores in patients on any modulator versus those not on it. And 57 of the participants, again, were on CFTR modulator therapy, and there is no difference in symptoms with these drugs. And so in Galaxy, this study was completed in 2019, so it was prior to the highly effective immunomodulator CFTR modulators being available. And we can see here that there, less than 5%, for example, were on triple therapy. Others were on ivacaftor and combination therapy. So again, it's important to know that the treatments, the CFTR modulator treatments, don't seem to be making big waves and changes in the GI symptoms. So again, that's a limitation that our study was done in 2019 prior to availability of the highly effective, modulator therapies. The majority of our patients were on some kind of treatment, some kind of GI treatment, that's 98%. Symptom scores were higher in those that were on treatments, such as constipation and acid suppression treatments. And the frequent use of these treatments, PPIs and constipation treatments in people with CF highlights that there's an unmet need, but now we have a group of electronically available patient-reported outcome measures that we can use that are, minimal variability and can be used to really assess these symptoms. And that we also know that patients on treatment still have, dissatisfaction scores that are high. So it remains really to be seen still what the impact of the highly effective CFTR modulators will be in people with CF. What's next for us? So Galaxy version 2.0, we're hoping to do a study on rifaximin for managing bloating in CF. This has now been funded by the Cystic Fibrosis Foundation. Thank you very much. And September was our start date, which we're working on all the regulatory paperwork now. PPI withdrawal study is being done now by Meg, and her surveys are done. So we are now in the design period of that. And then a thank you to obviously our mentors, Sarah Jane Schwarzenberg, and then Steve Freeman, who have really been fantastic. The Cystic Fibrosis Foundation, Jara Riva, who's been supported from the beginning, and then JP Clancy. And then acknowledgements also to the entire Galaxy team, the TD, NCC, Fung, Carmen, who was our initial coordinator that helped start all of this. Amr, Sonia have been amazing biostatisticians, the Cystic Fibrosis Foundation, all the research coordinators, and of course, all of you as investigators and the participation sites. We're also grateful to our CF patients, the families who supported this project, who were also involved with the community voice that helped us with all of those surveys at the beginning, and for all those that will continue to be involved in this research. Thank you so much.
Thank you so much. That was wonderful. Some questions or question from the audience was, do you use these questionnaires in your own practice, or would you recommend using them, or how frequently?
So that's a good question. So mostly in my motility practice, I use the Rome questionnaires where they pertain more to the general population. When I see patients with more systemic disease, the PAC-SIM is my go-to. Also, our pediatric colleagues can use that questionnaire. It's been used in clinical trials. And so that is part of the PROMISE questionnaires as well, which are these general NIH questionnaires that are being mandated for us to use. So I think if it's a clinical trial for a constipation trial, for a pharmaceutical drug, probably not. But if it's for just clinic use from one clinic to another in my multidisciplinary cystic fibrosis clinic, then absolutely, because I get to see, are the abdominal symptoms improving? Are the rectal symptoms improving? Are the stool symptoms improving? Because oftentimes things are very subjective, right? And this just kind of gives me a nice score so I can look at those sub-scores and really figure out, am I not treating abdominal pain? Am I not treating the other stool aspects of their constipation symptoms?
Okay, thank you.
Sure.
And I just had a question regarding the medications. There are a couple of questions coming in about the medications, but one question I had was, were you able to assess adherence at all to these medications? Was that captured in the study or not?
So no, these medication history was only obtained at the beginning. So that's at before the start of the study doing the screen. And then we no longer asked about compliance or any of that. So definitely that's a limitation of the study, and we should take that with a grain of salt. And then the other importance of the important limitation is that these were just patients in pulmonary clinics, right? They weren't patients that were in our GI practices. So this is kind of in pulmonary practice, what would happen normally in a patient that has CF, what GI symptoms they would have. So not in our specific digest group, GI CF clinics.
Okay, so following from that, the survey of the providers and their comfort level, were those pulmonologists or are they GI and pulmonary, adult and peds? Is that a combination?
That was mostly anyone involved in CF care. So it was also pulmonologists. It could be like APPs. Yes, certainly any dietitian that was in those pulmonary clinics filled out those questionnaires. Yeah, so just like everyone who takes care of any patient with CF.
Okay, perfect. And then there was a question about if there's any evidence that PPIs are effective in the adult CF population.
Well, I think certainly in the adult CF, there's more risk of reflux. There's more risk of Barrett's esophagus. So I think there are symptoms and dyspepsia. So dyspepsia, one of the treatments for just dyspeptic symptoms are PPI therapy. And then of course, with their pancreatic enzymes, many of them are on PPIs for better absorption. So I think there's definitely data that they are effective. In the CFTR population, with the CFTR highly effective modulators, we don't know, right? So I think MEG study, where we're looking at now withdrawal of PPIs in a stepwise therapy fashion, hopefully that will kind of shed light on whether we still need the PPIs for any of these symptoms. But I think that's something that's unclear. And then the fact that there's so much bloating, I mean, that was seen in so many of the patients with abdominal distension, fullness, bloating, and satiety. I think that kind of highlights that that's probably a future target for us to improve patients' quality of life.
Okay.
Yeah.
There's a question about sort of your management, sort of how aggressive you are with treating constipation, because we as we saw from your results, sort of all over the board in terms of comfort level with different constipation medications. Have you seen like more aggressive treatment result in better outcomes or quality of life outcomes, or what's your sort of management strategy?
Great question. So certainly in the general GI population, really treating constipation symptoms aggressively does improve upper GI symptoms. So there's a whole gastroparesis consortium with the NIH funds through the United States by the FDA, and they realized that 30% of their patients who have just gastroparesis actually also have constipation, and that treating constipation does improve outcomes, right? So that's just, again, from a GI dysmotility, general population of patients that are diabetics and idiopathics with gastroparesis, not cystic fibrosis. So I think this evidence we do not have in CF. And of course, by the time patients come to us as gastroenterologists, they tend to have more symptoms of constipation and others. So we probably do tend to be more aggressive. In the peds world, right, there's very few medications that are FDA approved that you guys can use, and you resort to the over-the-counter agents, which may be effective. But I think for the most part, most pulmonologists may not be, for example, aware that the GCC agonists have, peripheral neuromodulator capabilities. So when I tell those patients to use those drugs, even though they work on CFTR, they have other actions on the sodium channel, for example. I try to explain that this is not just for the constipation aspect. It also, those drugs have shown in clinical trials in the general population to help bloating and pain. And so I think, these drugs have different mechanisms of action. And so probably in my practice, I use a lot of the different ones, but perhaps in I think non-GI practices, it's much more difficult to be so familiar with the side effects and all the other mechanisms.
Yeah, definitely. There was a question that some patients consistently report improvement in GI symptoms when taking oral ciprofloxacin for chest exacerbations. So maybe that's from a SIBO treatment effect. So if ETI is improving lung function and there are fewer exacerbations with less need for antibiotics, could this contribute to more GI symptoms due to maybe less suppression of sort of a SIBO picture?
Yeah, that's a fantastic question. I think perhaps, right, it's plausible because ciprofloxacin is probably the third most common antibiotic that's used to treat just bloating in general. And many patients that have CF are on these antibiotics, multiple antibiotics, right? Whether it's amoxicillin is a prokinetic, azithromycin is a prokinetic, erythromycin is a prokinetic. I know that's not really commonly used, but these are all prokinetics in a way too. So they do have other effects, and perhaps they help with the dysbiosis at the same time. And, not being on them, would that suppress or would that cause SIBO? I think we don't know that because there's not easy ways other than aspirations of the small intestine, which is so invasive, to really document if there is bacterial overgrowth in any patients.
Yeah, exactly. There is a question about sort of these questionnaires, because obviously a lot of these studies are looking at differences, but symptom severity, sort of how is it scored? How is it assessed on these questionnaires? Is there a specific number? If they're higher than this, they're in the severe category, or how do they? Yeah,
so for many clinical trials, they go by a symptom score. Usually you do want the more severe patients, the moderate to severe. So usually any score change by like 1, it's really 0.75, but by 1 is significant to enter into a clinical trial. And then any change in score by 1 designates that there is improvement in symptoms, right? So whether it's a pharmaceutical trial or maybe a psychological treatment, otherwise, but this is based on the general population. So I think in our clinical trials, that should be the goal, of improvement for any, for example, the study we're going to do with Renzapride, or the studies we're going to do with, rifaximin for bloating. We would like to see a change, at least score change by 1 in whatever duration period we pick. And then there is a placebo response, right? So in any trial, there's always this 30%, 20% placebo response, even if it's inflammatory bowel disease, right? So even Crohn's, even ulcerative colitis, they do have a high placebo response, but that placebo response withdraws after a longer duration of study. So usually at 3 months for most of our studies in GI, and then also with collecting the most severe patients. So the degree of severity actually helps decrease the placebo response.
Okay, Thank you.
Yeah,
And
sure.
I think we have time for one more, which is many adult CF patients seem to have GI symptoms consistent with IBS. And I think that's probably true for pediatrics as well. And then should we treat these patients the same as IBS, or are there any specific things that you think about in the CF population where you would treat them differently?
Yes, so I don't like the term IBS only because, I mean, I have patients with IBS. So for the general population, but I think it's a little disturbing when I hear IBS with cystic fibrosis, only because it is a systemic disorder. There's a genetic, predisposition and all of that, right? So I think the term IBS is probably better termed, and that's why the whole Rome Foundation has also kind of changed these disorders to disorders of gut-brain interaction. But there is a visceral hypersensitivity as a result of having chronic disease that occurs in patients that have cystic fibrosis. I think since we don't have drugs that are necessarily, for example, for IBS with diarrhea, I use rifaximin, but we can't use it. It's not FDA approved for bacterial overgrowth, right? So we call most of the bacterial overgrowth patients IBS as well, right? Because we don't have another way to be able to give them the drugs without calling it something else. So I think, yes, definitely there is a visceral hypersensitivity that occurs in these patients. And when I sit down with the patient, I don't tell them it's IBS. I just say, these are functional symptoms. It's a result of your chronic disease, and it's a visceral hypersensitivity that has occurred as a result of having these syndromes. And much like phantom pain that occurs in patients who have a knee amputation or leg amputation, it's kind of like the same kind of process. Your body thinks the disorder is still present and it's very active, and it probably is because they've had chronic disease. And so the GI manifestations are much more exaggerated, and there's a decreased pain threshold as a result of having these symptoms. So no matter what, you probably do need to use a neuromodulator or some of these treatments that are targeted for IBS. I know that was like a long-winded way of
No, that was great. Thank you so much.
Sure.
Okay, so I think we're going to shift gears a little bit to the liver. So next is Dr. Michael Narkowitz, who will be discussing the final results of the PUSH study. Heterogeneous ultrasound predicts high risk for the development of advanced liver disease in CF children.
I would like to thank the organizers of the Cystic Fibrosis Conference for inviting us to present our work entitled Heterogeneous Ultrasound Predicts High Risk for the Development of Advanced Liver Disease in Children with CF. Today, I'm presenting the final results of the CFLD Network PUSH study. My collaborators are shown below. This is my disclosure slide. I have one potential relationship that will not impact this presentation. As the audience knows, advanced liver disease with cirrhosis affects only about 7% of individuals with CF. CF cirrhosis is primarily a disorder of children and adolescents, with non-cirrhotic portal hypertension now being the dominant form of liver disease in adults with CF. To date, there's no reliable marker that can identify individuals at risk for cirrhosis prior to the development of CF cirrhosis. Single center studies and our preliminary PUSH results presented 3 years ago suggested that a heterogeneous ultrasound pattern may be associated with an increased risk to develop advanced liver disease in children with CF. The CFLD Network PUSH study was designed to try and determine if truly a heterogeneous ultrasound can identify an increased risk for development of advanced liver disease using ultrasound pattern of a nodular liver as the endpoint. The primary aim of this study is to determine if a heterogeneous ultrasound pattern is associated with an increased risk for subsequent advanced liver disease as indicated by the development of the NOD pattern compared to children with CF who had a normal liver ultrasound pattern. Our secondary aim was to determine if initial clinical and laboratory variables can enhance the prediction of a subsequent risk of nodular liver. This is the report of our final analysis of the PUSH study. For the PUSH study, we initially screened 744 children aged 3 to 12 who were pancreatic insufficient enrolled in our multicenter prospective study entitled Prediction by Ultrasound of the Risk of Hepatic Cirrhosis in CF. For inclusion, children with CF had to be 3 to 12 years of age, diagnosed with CF by classical means, and enrolled in either the US or Toronto CF registry. There were stringent criteria for pancreatic insufficiency, as advanced liver disease is very rare in individuals with CF who are pancreatic sufficient. There were several exclusion criteria. Known cirrhosis or portal hypertension before enrollment in this study was an exclusion, as it was the endpoint. Burkholderia species on respiratory cultures excluded individuals because there was matching, and this would be very difficult. In addition, short bowel syndrome individuals were excluded. The primary tool for this study was a research ultrasound. For this, there was a single study radiologist identified per site. All of the radiologists underwent standardized training, overseen by the director of the radiology corps. Ultrasounds were graded as normal, heterogeneous increased echogenicity, which I will refer to as heterogeneous, homogeneous increased echogenicity, or nodular, by the consensus of 4 radiologists. Following the baseline ultrasound, subjects who were heterogeneous were matched to 2 normal subjects. Matching was controlled for age, Pseudomonas status, and center. All subjects underwent annual clinical exams, laboratory testing, and collection of biospecimens. Research ultrasound was performed every other year with a planned 6-year study. As I discussed before, the primary endpoint was the development of a nodular pattern on research ultrasound at the year 6 ultrasound, as graded by the consensus of 2 of 3 study radiologists. A 4th study radiologist was identified in case tie-breaking was needed and there was no consensus among the first 3. This occurred very rarely. Subjects with at least 1 follow-up ultrasound are included in these results. Subjects with a missing ultrasound at either year 4 or 6 or 4 and 6 had their most recent ultrasound used. Data are presented as mean plus or minus standard deviation with comparisons done by Fisher's exact with a target p-value of 0.5. We performed univariant and multivariant logistical regression models with stepwise inclusion of variables, adjusting for their baseline ultrasound to arrive at a final prediction model. These are the results of the individuals enrolled in this study. At enrollment into longitudinal follow-up following their baseline ultrasound, there were 62 subjects with a heterogeneous pattern with 123 matched normal controls. You can see the dropout throughout the visits. This left us for this report 55 individuals with a heterogeneous ultrasound and 116 matched controls. For the year 6 ultrasounds, you can see there were 47 or 75% of the initial enrollments with heterogeneous pattern and 101 or 82% of those with initially enrollment of a normal pattern. Demonstrated in this table are the key baseline characteristics at the time of their baseline ultrasound. There were no significant differences in age, weight for age Z-score, height for age Z-score, and Pseudomonas status. The heterogeneous subjects were more likely to be male, had higher GGT, ALT, and APRI scores, and had lower platelets at entry. So what are the final results? Individuals who were identified with a heterogeneous ultrasound at their screening baseline ultrasound, 33% of those individuals eventually developed a nodular ultrasound at their last follow-up. This is compared to only 4 or 3% of those with normal who were matched to the heterogeneous subjects. This results in a relative risk of development of a nodular liver of 9.5 if you have a heterogeneous ultrasound versus the normal matched controls. This is a significant increase in the risk for development of advanced liver disease. However, I will point out that the majority of individuals with a heterogeneous pattern still did not develop advanced liver disease. This led us to try and develop a multivariate model that utilized initial values from their entry into the study. I've condensed this so that you can actually see the table to show you the variables that were eventually selected in the parsimonious model. In this model, we held their ultrasound pattern stable. We found that age, log, GGTP, ALT, and APRI significantly enhanced the ability of the parsimonious multivariate model to identify individuals at increased risk for the development of NOD over time. We also included FIB4, but we found that FIB4 and APRI track concurrently, and we excluded both stepwise FIB4 or APRI and found that APRI was a better component to this model. Shown in this graph is the receiver operating curve for the selected model. You can see the area under the curve, or R value, is 0.9, indicating excellent prediction for this model. Now you might ask, is nodular liver a good endpoint for the development of advanced liver disease? I'd like to share with you two data points of clinical data that would suggest that this indeed identifies individuals with advanced liver disease. Shown here are the graphs of individuals who had heterogeneous liver that eventually progressed to NOD compared to the heterogeneous group not progressing to NOD and their platelet count over time. You can see with the development of NOD a significant and rapid decline in platelet count compared to those who did not develop a NOD. This suggests the development of clinically significant liver disease. This is also shown in the spleen size Z-score. In the individuals who progressed to NOD, there was gradual increase in the spleen size Z-score with no significant increase in those who did not develop NOD. Thus, this appears to demonstrate significant liver disease develops in parallel with the development of a NOD ultrasound pattern. In conclusion, we've shown that research-based ultrasound identifies children 3 to 12 years of age with CF at an approximate 30% risk for the development of NOD ultrasound pattern by 6 years of follow-up. Further, a score based on ultrasound pattern, age, APRI, ALT, and log GGT may provide a useful tool for further identifying children with CF with a higher subsequent risk for development of advanced liver disease. Again, the majority of children with heterogeneous pattern do not develop NOD pattern by 6 years. And thus, we believe further biomarkers are needed to refine this model. Finally, I would like to point out that this was done by research ultrasound consensus grading. And so the prediction by our research ultrasound does not necessarily translate to an equivalent performance for individual radiologists reading clinical ultrasounds. Thank you very much, and I'm happy to take any questions.
Great. There is a question from the audience. Thank you, Dr. Narkowitz. Great talk. And one of the questions was, what percentage of those with nodular liver go on to develop advanced liver disease?
So thanks, Nicole. I'm going to interpret that question to mean develop signs of portal hypertension because that's, I think, where we're talking about this. So we're ongoing, these subjects are in ongoing follow-up. To date, we have had 3 subjects develop variceal hemorrhage and 1 subject advance to transplant. I think it's a really important question. What is the time frame from identification of an ultrasound indication of structural abnormalities to clinical presentation? And then the flip side is, do all of the individuals eventually develop at portal hypertension signs and symptoms. And I think we don't know that. I think the data I showed about declining platelet count and increasing spleen size, and we also have some parallel data on transient elastography, suggest all of these individuals do have some degree of portal hypertension, but it probably is not fully manifest.
Okay, thank you. Question about any data on synthetic function.
Yes, we collected data on INR, bilirubin, and none of these individuals had abnormalities in INR or bilirubin to date.
Great question saying, should we challenge the notion that once a patient reaches a certain age, they would be out of the woods with regards to developing significant portal hypertension or synthetic dysfunction?
Yeah, that's a great question. I think if you look at the pediatric and adolescent population, it's clear that advanced liver disease, what we really think of as probably biliary cirrhosis, although it may not be, is diagnosed at about a mean of 10 years of age. And at least looking at the large study that was a genetic modifier study, there were very few individuals identified with advanced liver disease over 20. That data, though, was based on really almost a different era now of care. And what we are clearly seeing in reports is that there is a vasculopathy that occurs in cystic fibrosis that appears to be making a much stronger appearance in the adult population. And so while it may be true that cirrhosis, you're out of the woods, it does not, I think, eliminate the risk for portal hypertension due to non-cirrhotic causes. So I think the short answer is you got to worry about it even in your 40 and 50-year-old CF adults.
I have a question about sort of this study, and has it sort of changed your practice at all? Do you do anything differently in clinical practice if you see a patient with a heterogeneous ultrasound in terms of following them, monitoring them, or how do you?
So that's the $1 million question. And I think there's another question sort of similar to this coming up. So I've been really careful in the way I present this, in that this is 4 radiologists, all of whom were individually trained and looked at this. But since this is a clinical question, I will give the viewers an insight. We took the individual reads and we looked at those to see if they were predictive. So we took whatever the site radiologist read was, not the consensus read, because there was some variability. And then we looked at the ability to predict. The data that I would say you can take from this is if there's an interpretation of a normal ultrasound, either by our consensus readers or by our individual site readers, it had a very good negative predictive value for the development of a nodular pattern. In other words, very few. It actually has a 96% negative predictive value. Now, normal ultrasound is more frequent than an abnormal ultrasound. So you have to take that for a grain of salt. So I think in individuals who do not have clinical signs of any other clinical signs worrying me for liver disease, who have a normal ultrasound, I'm not too worried about those individuals. If there are imaging abnormalities, the prediction of risk from an individual reader is nowhere near as good as it is from a consensus. But those individuals I do follow more closely and feel that they probably merit more close laboratory analysis, because as you saw, you can see some platelet decline in those type of areas with them. You will hear in the subsequent talk, which is based on this, why I think biomarkers may be more helpful, but I'm not going to steal that thunder.
Great. And then sort of a question from this, obviously this was a research-based ultrasound, as you made clear. Is there any guidance you can give for radiologists or how they could standardize training and scoring?
Great question. We're actually working on a manuscript to describe our training and scoring and make our training materials available. So as one of the goals of this study was to really try to be generalizable to the general CF community. And the reason we chose ultrasound as opposed to MRI or something else, was the generalizability. So that will be available once we publish that. I would caution all the audience in that there is significant variability, even among our research-trained ultrasonographers and radiologists. And the most difficult and most variable was identification of a heterogeneous ultrasound pattern. That's where the variability was. What I didn't mention is we actually also only used a single research radiology technician to do the ultrasound. So we tried to eliminate as many variables as we could. So we not only had training for radiologists, but we had training for the ultrasonographer techs. And each one had to then, if we had a new tech, they had to get further training. So this is, it's a little bit difficult to replicate in a clinical setting.
Okay. I think we've gone through all the questions. We will move on to our final speaker. So that's Emily Scala, who will be speaking on plasma proteomics identifies vascular disease, thrombocytopenia, fibrosis, and dysregulation of lipid transport in CF patients 3 years prior to nodular liver ultrasound.
Hello, I'm Emily Scala, and I'm a research assistant in the CIADI lab at Cincinnati Children's Hospital. I would like to thank the CF Foundation for inviting me to present our work. Today, I'm going to discuss our most recent proteomic analysis of plasma samples from CF subjects with normal, heterogeneous, and nodular liver ultrasounds. The data in this presentation is the subject of an invention disclosure, Narkowitz-Ziadi, at the University of Colorado School of Medicine. First, a little background. The mechanisms of CF liver disease are poorly characterized, and there are no reliable tests to predict which children will go on to develop advanced CF liver disease or when. This is important because CF liver involvement can affect 30 to 40% of children and adolescents with CF. According to the CFF Patient Registry Annual Data Report for 2019, CFLD is the third leading cause of mortality, and significant liver disease occurs in more than 9% of individuals with CF. Premise and hypothesis. One approach that may delineate the underlying mechanisms and biomarkers of disease is to examine the expression levels of proteins in plasma by proteomics and assess any relationship to disease processes by pathway analysis before patients develop abnormal ultrasounds. We hypothesize that an examination of the serum proteome of CF participants that develop future abnormal liver ultrasound versus matched CF participants that do not would identify disease markers and pathways associated with the development of liver disease. Prediction by ultrasound of the risk of hepatic cirrhosis in CF, or PUSH, is a prospective study. First, baseline plasma samples were collected from enrolled participants and they underwent research ultrasounds. Then a grade was assigned to each ultrasound by consensus of 3 study radiologists to have either homogeneous, nodular, normal, or heterogeneous liver ultrasound. Then the normal liver ultrasound cohort was matched by age, center, and Pseudomonas infection to the heterogeneous cohort. Longitudinal follow-up ultrasounds were to be performed. After the year 4 ultrasound, it was again given a grade by consensus of study radiologists. Then we selected our samples for analysis. 18 subjects with normal liver ultrasound whose pattern did not progress over 4 years. 11 subjects with heterogeneous liver ultrasound whose pattern did not progress to nodular over 4 years, and 11 subjects with heterogeneous ultrasound that went on to develop nodularity deemed to be consistent with cirrhosis. The samples in our analysis were collected years before nodularity appears on an ultrasound. Here is our discovery proteomic analysis workflow. First, albumin is depleted from the sample, and plasma proteins are fractionated by gel separation and liquid chromatography. In-gel digestion is performed, and tryptic peptides are extracted. Next, we identified protein isoforms using a cutoff of at least 100 mass signatures per protein. Our coverages ranged between 1 and 100%. We used mass spectrometry-based label-free quantitation. Although MS is semi-quantitative, the high number of mass signatures per protein increases our accuracy. Finally, differentially expressed proteins are reduced to top candidates. And pathway analysis of top changes are conducted to rank changes in biology. Plasma analysis for CF-LD project. We completed analysis of all samples, which included a 15-hour sample runtime. Our most recent analysis included a deep mining MS analysis with high stringency database searches. After the completion of the MS analysis, we were unblinded to conduct bioinformatic comparisons of groups. When looking at our most recent analysis, comparing those who remain normal and those who develop nodular liver ultrasounds, we observed diseases associated with vascular abnormalities and thrombocytopenia. When we look at the top pathways by p-value, when comparing those who remain normal and those who develop nodular liver ultrasounds, we observe immune responses, complement, lipoprotein metabolism, assembly, and remodeling, and CFTR-related pathways. When comparing samples from subjects who remain normal and those who remain heterogeneous, we continue to observe associations with vascular abnormalities and thrombocytopenia, and we also observe associations with lung diseases. When we look at the top pathways by p-value, when comparing those who remain normal and those who remain heterogeneous, we observe enrichment for blood coagulation, smooth muscle contraction, and lipoprotein metabolism. When comparing those who remain heterogeneous and those who develop nodular liver ultrasound, we continue to observe disease associated with vascular abnormalities and thrombocytopenia, and we also continue to observe strong associations with lung and liver diseases. When comparing those who remain heterogeneous and those who develop nodularity, we observe enrichment for coagulation, immune response, complement, migration, and also lipoprotein metabolism. We also analyze proteins that are present in those who develop nodular liver ultrasounds and absent in those who remain heterogeneous to be able to distinguish the cohorts. With network analysis, we discover strong associations with negative regulation of cholesterol transport, inorganic compound detoxification, and cholesterol esterification. With network analysis of proteins only present in those who remain heterogeneous and absent in those who develop nodular liver ultrasounds, we discover associations with positive regulation of cell development, phospholipid remodeling, vasoconstriction, and fibrosis. To summarize, the major features of differences are, from highest to lowest, coagulopathy, vasculopathy, blood platelet disorder, hypertension, complement activation, and lipid metabolism. Proteomic analysis of plasma identifies CF liver disease-related pathologies years before patients develop abnormal liver ultrasound and can serve as a prognosticator of the risk of liver disease in CF. The data suggests several disease differences, including a prothrombic and complement-driven inflammation phenotype in those who remain heterogeneous and those who develop nodular liver ultrasound, higher in nodular, increased blood vessel hardening and angiogenesis in those who develop nodular liver ultrasound, Distinctions between those who remain heterogeneous and those who develop nodular liver ultrasound include differences in liver and fat lipid metabolism and wound healing phenotypes. I would like to thank Drs. Ziadi and Narkowitz for the opportunity to work on this project, the CF Liver Disease Network, the Ziadi Lab, and the grants which supported this research.
Thank you so much, Emily. That was really fascinating. And we do have some questions or a question about, obviously people are tempted for more. What are future studies planned to further narrow down the utility of proteomics in predicting liver disease progression in CF? Well, I think, I don't know if we're having trouble hearing. Sorry, Emily.
Emily, you want to try again? Can we hear you? So Nicole, can you hear me, Nicole?
I can hear you. I just can't
Okay.
hear Emily.
It sounds like she's having some technical problems, so I'll try and answer this in her absence. So what we're planning to do right now is we're actually doing a confirmation study, trying to identify selected proteins and see if we can identify them by a different methodology, so immunoassays. And if we can identify them by immunoassays,
can you hear me now?
Yes.
Okay. So first, what we need to do is be able to validate our findings. So we need to get a new cohort of samples, like maybe the PROMISE study, and be able to run our same pathway analysis with what we did with this study and see if we can get the same results.
Okay, fantastic. There is another question about if OP cultures are so poor in sensitivity, should we be getting induced sputum as more of the norm in terms of sample?
I am going to phone a friend and see if Dr. Narkowitz can handle this question.
I'm actually not quite sure I understand the question, Nicole.
Yeah, I'm not sure. I guess what we were using for your samples, maybe what were you using? I guess, and this might be from something unrelated.
I'm not quite sure how this relates.
Okay.
If it could be that they're using the analogy of oropharyngeal cultures have poor sensitivity and specificity, didn't induce sputum. I think you could consider
maybe you're using serum, right?
Yeah, we're using serum. So unless whoever asked the question could put something in clearer, I think we're stumped.
And also sputum is a lot more difficult to analyze on the proteomics side point. There's a lot of other variables that are introduced with sputum as opposed to running a plasma sample like in this study.
Other questions? Guess I have a question. Do you are we from the clinical side from the study recommending sort of any more sort of like lipid screening, cholesterol screening, checking for that in our CF patients with liver disease?
That's a great question. So the lipids came up in our analysis. So testing for that could be a good indicator of what could possibly be potentially a biomarker. And same for like the blood clotting factors, and yeah, with like lipid metabolism showing up and blood coagulation with our pathway analysis.
Okay. And then there was a question saying, any advantage of adding metabolomics to proteomics?
You want to phone a friend here, Emily?
Okay, yes.
So we actually did do a metabolomic analysis as part of this study, and it had it yielded no results of any interest. So we've gone down that pathway already.
Okay. Fantastic. I don't see any more questions coming in. So I just would like to say a huge thank you to all our speakers. Really, really interesting and varied talks and a lot to think about for the future. So thank you, everyone.
Thank you.
Thanks.